Hi, this is Brian Kim. I'm going to share with you this case of a patient who had cataract surgery and a Panoptix Toric IOL placed. This is a soft lens, and you're going to see double chop, cross chop, mechanical fracturing techniques, and how I align this Toric IOL. So I'm going to use a cotton tip to help straighten the eye, and then I'm using a corneal marker which will help me to center and size my rhexis. I'm using the cotton tip now to turn the eye so that I can make my paracentesis incision on the right side first, and then on the left side, you're going to see I'm using the cotton tip so that I can have a flat approach with my incision parallel to the iris plane. That flat approach allows me to create a nice corneal shelf, which will allow me to make a self-sealing corneal incision. I'm injecting some intracameral lidocaine and then dispersive viscoelastic. I'm using the cannula to hold the eye. I make my triplanar corneal incision, make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and using the cannula to control the eye, I'm able to enter. That's a triplanar corneal incision. Now I'm going to do the puncture style capsulorhexis, puncture with the teeth of the rhexis forceps, and then with the teeth closed, I'm gently, bluntly trying to manipulate the tear so that I can create a flap. I'm grabbing the right side of the tear to create the flap. You want to make sure it reaches to the periphery to a certain extent, and that will determine the diameter of your rhexis. So I'm going around circumferentially, grabbing and re-grabbing, making sure I don't put too much stress on the wound. And I'm going around, trying to make sure the rhexis size matches with my corneal marks. And this is particularly important when you're dealing with a toric lens. So I finish off the rhexis, burp some viscoelastic. This is a Capsulorhexis hydrodissection technique. I place the cannula out to the contralateral equator underneath the rhexis edge, point the tip down. You get a nice fluid wave decompress on the right side, and the lens begins to spin on the right side, pointing the tip downward. So I'm irrigating the surface of the cornea and making sure my sleeve is adjusted appropriately. I lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. Start to remove the surface epinuclear material. Place the chopper underneath the epinuclear ridge. Point the tip down. Place the phaco tip vertically subincisionally. Bring both instruments together, and it crushes it with mechanical fracturing forces. That's the double chop. Place the chopper around the contralateral equator, pulling it centrally towards the phaco tip, crushing the right heminucleus in half. That's the cross chop. I use high vacuum to pull that first quadrant up and then get around it with the chopper and crushing it against the phaco tip with mechanical fracturing forces. I place the chopper around the second quadrant, pulling it up out of the bag, and then crushing it between the chopper and the phaco tip, and using high vacuum as well as mechanical fracturing forces. Rotate the second heminucleus in front of me, place the chopper around the lens, keep the phaco tip deep in the bag, pull the chopper centrally, crushing the lens in half. This is a soft lens, and it didn't really come up quite easily, so I had to go around it and crush the lens again with the chopper against the phaco tip. Now that the third quadrant has been fully emulsified, I place the chopper around the fourth quadrant, pulling it centrally towards the phaco tip, crushing it and sandwiching it with mechanical fracturing forces, and then using high vacuum. The remainder of this is essentially epinucleus. I'm using high vacuum to grasp the anterior portion of the epinucleus, which causes it to tumble out of the bag. And then I'm grabbing the subincisional epinucleus. So I take the chopper out, push BSS in, take the phaco tip out, and then I go in with the INA handpiece. I start subincisionally grasping the anterior portion of the cortex, peeling it from anterior to posterior, and I'm going around circumferentially, repeating the same steps. I always start subincisionally because I feel like that's the best time to be able to get to that subincisional while the rest of the cortex is keeping the bag concave. Once all the cortical material has been removed, I switch to the polish mode and I start polishing underneath the rhexis edge with this soft polymer tip. It's very gentle, and the polish mode is really a very great setting to gently polish the capsule without causing any damage. I start to polish the posterior capsule surface as well. You can see I'm doing very gentle, small strokes because I don't want to accidentally grab and pull on the capsular bag or zonules inadvertently. I use a BSS cannula to pulse subincisionally, keeping the eye inflated with the INA handpiece. In this case, the bag is clean. And then I'm injecting some cohesive viscoelastic to fill the capsular bag. And then through the other incision, I'm going to use the capsule sweep to polish underneath the rhexis edge. I polish on the left side, and then I'll polish on the right side. I don't like to polish into the fornix because I don't feel like there's much utility to do that. And plus, you're going to start to rub against the iris and cause more pigment liberation. I just polish along the rhexis edge 360 degrees. With the sweep in the eye, I go in with the single piece acrylic intraocular lens into the capsular bag. The leading edge is in the bag, the trailing edge is out of the bag. As the lens unfolds, I go in with the INA handpiece, activate the irrigation, inflate the eye, and then make sure that leading haptic and trailing haptic are disengaged. Because I know the orientation of the lens, I just decided to go under the lens there, tilt it up, remove the viscoelastic from the bag, rather than spinning the lens within the bag in order to get close enough and approximate the orientation for the axis. Once I've removed all the viscoelastic from the bag and underneath the rhexis edge, start to remove all the viscoelastic from the anterior chamber. I like to remove all the viscoelastic from the anterior chamber because I know that the last step needs to be the final position of the lens. If there's still viscoelastic in the bag when you're trying to achieve final position of the lens, that viscoelastic can affect the position of the lens. So make sure you remove all the viscoelastic from within the bag and into the anterior chamber as well. And I use the INA handpiece to basically orient the lens into the 180 degree axis. I believe it's around 175, but essentially you can see that the marks are lined up with my ink marks there. And I basically turned the tip of the INA down and hooked it around the optic haptic junction to turn the haptic in the horizontal meridian. So I hydrate my incisions, and you can see that I made sure that the eye was inflated, and I was pushing BSS as I took the INA handpiece out. Again, I used the INA handpiece to rotate the lens into position without having to do any other manipulation. In this case, this patient has a deep eye and a little bit of a reverse pupillary block situation. So I lifted the iris with the irrigation cannula to achieve adequate pressurization without keeping that reverse pupillary block configuration. So you can see this case looks beautiful and the lens is on axis. So I hope this was helpful to you, and I thank you for your attention.